Hey, hey everyone, thank you so much for joining me in my master video. Today I have with me Dr. Valerie Kreider, who specializes in Gestalt therapy and also in treating schizophrenia as well as the model called CBT for psychosis. So we'll be talking about perhaps some areas that overlap between schizophrenia, psychosis, and schizoid personality. So things like maybe overstimulation, hypersensitivity, negative symptoms, metacognition, and this form of maybe therapy treatments for schizoids and schizophrenia. So Dr. Valerie here, she's a trainer at Northeast Ohio Medical University and also Gestalt therapist, right?
Right. Yeah.
What else do you do, Valerie?
Gosh, what else do I do? Anything with therapy.
So what initially got me interested is you do work with this model for schizophrenia called CBT for psychosis. Would you like to tell us briefly a little bit about this model? Like, what's the theory behind it? What's the methodology?
Sure. It almost seems counterintuitive, doesn't it, to use a cognitive-based therapy for a disorganized thinking process. Cognitive behavioral therapy for psychosis uses the same model as a traditional cognitive behavioral therapy model. In the traditional model, though, for people without psychosis, it's a fairly directed, compacted type of therapy, very educational, kind of almost directed, lots of homework, lots of practice. And those who struggle with psychosis experience may have a hard time hanging on to that. Sometimes their capacity for memory is taken up by voices or hallucinations or maladaptive behavior strategies to self-soothe. So it needs to be very different flavor of CBT. It needs to be done with the same components in mind, thoughts, behaviors, and actions, with the understanding that the person that you're working with really does in fact see and or hear or experience the world really differently than I do, right? And so we can see that somebody who is having auditory hallucinations, for example, we can see that on a PET scan as it happens. The hearing place of the brain actually lights up. So it's very different than, those voices aren't really there, are they? Can you tell me a little bit about what the voice is like, what the voice is saying? So it's a more exploration of those psychosis type experiences, both visual, tactile, and auditory. So we're very interested in finding out about those experiences if the client is willing to share. It's done very compassionately with a lot of genuineness and a lot of acceptance without any judgment at all. So it's a lot of acceptance and compassion goes into this kind of therapy. We never say that, the hallucination is not there. We never say that. That is absolutely not true. Because in their shoes, it absolutely is there. So we're not going to invalidate that in any way, shape, or form. In truth, it's about, I guess at the end, CBT for psychosis is about changing one's relationship with the symptoms rather than allowing the symptoms to drive the behavior. We can actually help people change the relationship that they have with the voices. Sometimes people will get very angry at the voices because the voices can be mean. And we've discovered that if we actually set up almost a conversation with the voices or have them role play, addressing the voices in a more compassionate way, that the voices will ease up a little bit. We're aware, too, that many times the psychosis experiences that we're working with in a client is very, very reflective of their own life history. So I was talking about a client today who is scared to go outside because he's afraid that there are kids in the neighborhood that will bully him or kill him, stab him or shoot him. This is a young man with his whole life out in front of him. He was 18 or 19 when the symptoms began to happen. And then they did begin to happen. And it was kind of a paranoia type thing. And when we look into his history, we can see why that might be. There was a history of sexual abuse, abandonment. There was hereditary vulnerability to the disease as well, or to the condition. I don't really want to call it a disease, a condition. So he had a lot of things to be afraid about when he was growing up and where to go. And so I was watching you on a previous YouTube episode talking about dissociation and thinking, gosh, that makes a lot of sense, that dissociative quality, particularly if we have parenting styles that are not affectionate, not attachment oriented, not positive, not intimate. Then this person is just, overwhelmed with loneliness and may get some harsh messages and may develop some own messages of their own because of the neglect that they receive. So there's a lot of self-shame. There's a lot of self-stigmatism as a result. I'm sure with schizoid personalities, it's very much the same, right? So we also try to normalize the condition. So most of us have probably had some kind of an experience where we thought someone was calling our name, or we heard our phone ring and it really wasn't our phone and nobody really called us. That's kind of by definition, hallucination, right? Right? So we've all had that, and it goes on a continuum. And if we can normalize that continuum, like some people have it a little, some people have it a lot, then it's not quite so scary. And many people do, as it turns out, have the capacity to think well, to organize their thoughts, to have a different relationship with their voices, even if the voices are residual after medication, and live more full, rich, meaningful lives. I don't know if that gives a concise definition or not, but that's what I'm hoping for.
Perfect. So it feels like there's a lot of respect for the clients, for the patient's experience, that it is real for them to experience these hallucinations or delusions, even though on the outside for the other person it might seem like nothing is there, but for them their experience is real, and I think that's what really matters. Yeah, so it's not like something to change or get rid of this symptoms or whatever, but just work with. Well,
yeah, absolutely.
Yeah. So in previous discussion, we talked a little bit about this whole idea of overstimulation when it comes to schizophrenia and the relationship between overstimulation and negative symptoms.
Oh, yeah, that's a very good question. So the theory is, with schizophrenia, the main neurohormone at play is dopamine. So we've all seen, serotonin reuptake inhibitor commercials for antidepressants and stuff like that. Serotonin is one, dopamine is another. Dopamine is the feel-good neurohormone, or it's the hormone that makes you go, oh, that was great, after you drink a cold glass of water on a hot day. It's that, oh, it's lovely. And most of us have a dopamine burst, I guess you would call it, after something we do that feels good. Drinking a glass of water, getting a reward, eating, that kind of thing. For those with schizophrenia, it would appear that and it also helps us to know, by the way, dopamine helps us to know what's important in our environment, what to pay attention to. So dopamine isn't well managed in a brain that experiences psychosis. Sometimes that dopamine isn't managed just when there's something to pay attention to, but the dopamine burst happens randomly all the time. So maybe there's too much dopamine going on. So if I were to walk into my office, for example, and I would see a chair, a window, maybe a plant, the desk. Normally, I would pay attention to what's sitting on my desk, the chair, if I'm cold or hot, getting ready to comfort myself, because the work is what's important, and that work sitting on my desk is important. But if I'm having too much dopamine in my brain, kind of bursting out randomly, then suddenly everything becomes important. And it's hard to distinguish how they're all connected. So is the lamp connected with the desk somehow? Or is the desk connected with the chair? Or how is the window involved? Is there somebody outside the window? And what happens is the brain is trying to make a pattern where there isn't one, but our brains are designed to do that, right? To make a pattern.
Mm-hmm.
It's working furiously, and it comes up with something that isn't quite right because the neurohormonal balance is not regulated well.
Mm-hmm.
There's also environmental factors that can create a spurt of dopamine, and glutamate is another neurohormone that is active in the schizophrenia process. So when everything is important and everything is going on, our brain kind of overloads. And in order so that speaks of overstimulation. When the brain is overstimulated, it wants to just shut down because it can't manage it all.
Yeah.
It's just, I want to go down. And so that negative symptom that's called a primary negative symptom. In other words, it's a primary in terms of it's directly from the condition of being overstimulated. The brain just wants to shut down and kind of ignore everything. And then you get very flat and don't want to move. And that's a result of being overstimulated. Now, in schizophrenia, that looks a lot like being lazy, but it's not. So oftentimes people with negative symptoms, whether it's schizophrenia or schizoid or depression, whatever it might be, there's a lot of outside criticism because it just looks lazy, unmotivated, right? So a lot of criticism comes. When the criticism comes, it just adds a burden to what's already happening. And then we go, why bother, right? And so then folks who struggle with these kinds of experiences tend to state themselves, feeling like if they ever reached out, they would just get criticized yet again, Mm. So that's part of what a negative symptom is. Negative symptoms can also be caused by medication. If somebody is beginning a new medication, sometimes it can be very sedating to begin with, maybe for months, until the body gets used to that. And we call that an iatrogenic effect. It's a not so good side effect of medication that needs to be sometimes treated in and of itself, right? And so we have to be careful of that and careful of not trying to expect more from the individual than what they can give when they're so sedated like that, right? Or to kind of work with the psychiatrist to tweak any medications that might help with that heavy sedation that they feel.
I see.
Yeah, and those are called secondary negative symptoms. Yeah.
I see. Related to medication in that case. Okay. Yeah. This is very interesting because I hear over and over again, either from people who have been diagnosed with schizoid, or I talked before to Dr. Nancy McWilliams as well, and she suggested she has this, this theory that there's this ongoing over or hypersensitivity in people with schizoid personality. And I'm curious if this is like a similar process to this overstimulation that you are describing, because I hear over and over again, like, this is too much, and maybe it could be auditory, like there's too much noise or too much feelings or too much this, and what happens is that people with schizoid personality, they do tend to, go into this kind of negative state, like apathy and like not caring and shutting down basically. So then you have outwardly, it seems like they don't care, right? They
Right.
like you described it, they're lazy, they have no feelings, but there seem to be this kind of mechanism related to hypersensitivity. So
Yeah, I think that can be very true. And as I read, after you and I initially talked, I did some of my own reading because I may have family members, distant family members, who have experienced this kind of a personality. That it does appear to be, it's the world is just too much. The world expects too much of me. And so if we're growing up in a home where there's really a lack of affection, nobody to share good or bad experiences with, nobody to talk a process through with, then we have no foundation for building a self, really. We have no feedback from the rest of the world. There's no ground with which to build figures that enter into our world. And so we really need to have that as reparative kind of work to help the individual learn to process what's happening around them more easily. Does that make sense?
yeah. So in this context, do you think it's the same process like with schizophrenia? The one that you described, that we do need to learn how to process, how to build the self. So if one is somewhat isolated, maybe, or doesn't talk about their feelings in family,
Mm-hmm.
then they don't get a chance to develop that.
Well, in schizophrenia, there is such a hereditary factor involved that
Right.
sometimes that can be a child can have a great bringing up
Hmm.
experience, completely perfectly normal, have a prodrome, and then off they go, and everything this individual has worked for. Maybe I've seen straight A students and PhDs all of a sudden have their first psychotic experience and lose everything. And you can tell, talking with them, and you can see through the history, that nothing happened to them. They weren't isolated. That seemed to be a real genetic involvement there somehow. And I can look with a client's history about that. But it can also be as a result of environment, that diathetical thing, environment and hereditary vulnerability together. So about half of the people with schizophrenia, maybe more than that, actually are probably have the criteria for post-traumatic stress disorder as well from
Right.
childhood abusive situations. I would imagine that perhaps a greater amount of those with a schizoid type personality may have experienced more of that, but I don't know that for sure. I don't know that for sure because that kind of speaks of the building of a foundational personality, right, that is guided
Yeah.
by outside others oftentimes, right? But I don't know that for sure. But I would guess that there's an awful lot of abuse and trauma in the histories of those who struggle with building relationships with others.
Hmm. Right. But there might be some. Yeah. So I guess it's the same like most other sources say, that there are some overlaps between schizoid and schizophrenia, but there are obviously some differences as well.
Mm-hmm. Yeah. Well, and schizophrenia is very heterogeneous. In other words, everybody's schizophrenia is different from everybody else's schizophrenia. And so
Mm.
it's very hard to kind of figure it out sometimes because everybody has a different constellation of symptoms. Um, and we also consider schizophrenia to be a symptom of some other underlying issue. So we see schizophrenia as a symptom rather than a disease itself, or the hallucinatory experiences as a symptom. Now with schizoid, I don't know if it's more of a symptom or if it's a defense mechanism with which to keep oneself safe from a seemingly difficult environment.
Right. So the schizoid personality is more of a obviously like a structure of the self configuration kind of thing. Whereas schizophrenia is, how would you describe it in contrast to that?
Oh boy, I would say that the process of developing schizophrenia does involve building the structure of the personality.
Mm-hmm.
So as I grow in my personality, I have a particular personality. If I develop schizophrenia, that's going to do something to my already existing personality.
Yeah, I see.
Or if I come from a terrible background and there's genetic vulnerability and that switches on early because of the stress, then that also adds to the building of my personality. I'm guessing that those with a schizoid personality kind of just grow into that. Do you find that to be true?
I would imagine that, I mean, the way I think about it is whether it's a personality type or you call it a disorder or style, whatever you call it, it's something that, yeah, like you said, like grow into it. Like it starts early on and it develops over
And it
time.
develops. And, one of the things that I know about adding things to our personality in order to keep us safe is that in childhood, we do that for a very good reason. And it often works really well, isolating, staying away, hiding.
Hmm.
That works very, very well as a youngster. And the first thing that we learn to do as very young children is to read body language more than anything else before we even speak. So we're starting to learn to pull away or come close before we can even utter the words.
Hmm. Yeah. Do you, do you know if for people who have, let's say, the later onset of schizophrenia, like, when they are an adult, do you know if they also have this tendency to get overstimulated as children, or is it something that comes later?
I don't know. That's a really good question. I don't know. That's interesting. I know I have had clients who had, I really don't know that for sure. I'm thinking about a particular client that I had who grew up in a difficult home. His mom had schizophrenia. Brilliant. Both of his parents were very brilliant. And when the parents divorced, he was put in the care of his mom, as was the routine back in those days. And at the age of 6 or 7, I want to say, he ran away from his mom's apartment in New York City to go find his dad's apartment in New York City. He did that all on his own 3 times before they finally recognized that he really needed to be with his dad. And dad had a very large, directive voice.
Right.
Their background was Middle Eastern and very just a strong male presence. And
Right.
I know my client, by the time he came to me, um, had developed a dislike of loud voices. Even with medication on board, if somebody's voice raised to a certain level, he could not tolerate, his voices would come back. And so
Hmm.
he had to train his family. He ended up, but boy, by the way, he's got a PhD in economics. He's doing very, very well. He still experiences voices on occasion, but he's learned to train the people around him to speak at a lower level and to speak more kindly and respectfully to him than they otherwise normally would in their family, so that his voices don't come back,
Hmm.
that kind of thing. So he really learned how to remove that stimulation from his life. And he described life growing up as dad was very loud, right? And so he developed a kind of a
Mhm.
fear, or it became a cue for him. So I don't know, but it's a great area of
Maybe
creation.
someone would be interested in researching that. Yeah.
Yeah.
So this kind of experiences, like with that client, with that patient, regarding the voice, um, that got me thinking. Like, do you think there are like any patterns in terms of what could be overstimulating? Like, have you observed throughout your like
What would be overstimulating?
career? What could be stimulating? What, yeah, or
Um,
overstimulating for people?
the Gestalt, the periodical Gestalt Review is a great periodical, great journal. And in one of their journals years ago, they devoted a whole journal to using Gestalt with psychosis, which is actually really cool journal. That was a cool volume. And they talked about high emotional expressiveness as being overstimulating, right?
Hmm.
So if there's a family with a lot of loud emotional expression, that might be, as in my client's family, that might be overstimulating. And I know as a little girl growing up, my best friend was half Italian and half Jewish. Like her parents were immigrants. And in the backyard, you could hear them having a family picnic from 3 miles away.
Yeah, I would imagine.
And, here I was, this like, little waspy girl that followed all the rules. And my life wasn't like that at all. It was a very interesting experience to go back and forth between the two. Her family would make me nervous because they were so emotionally expressive. However, if we take cultural considerations into perspective as well, some cultures, for example, find that high emotional expressivity is a sign of care and love. That means that they love me. And so we need to be careful about guarding against that, right? Because we need to take into consideration their cultural views and have that fit with their life, accommodate to their life, I guess, right? Adapt to their life.
Mm-hmm. Right. So it probably depends on client's background, the
Mm-hmm.
culture they come from.
Right.
Yeah. But generally, there might be this content, like highly emotional experiences, let's say.
Right. Really arousal, right? A lot of arousal, emotional arousal. And so even when I'm working with somebody with schizophrenia, I'll rarely ask them, how do you feel about that? Because I don't want to really touch on the feelings all that much, because that can begin to work the emotions. And I'm not sure that I want to do that unless they want to go there.
Mm-hmm. Okay. So in terms of the model that you've been working on, working with in training other people, the CBT for psychosis, are there any methods or treatments, or maybe in simple language, like how do you handle the overstimulation in clients? Like, do you teach them something, or do they need to develop something to handle it?
Yeah. You know what? There's also something else that I want to say about treating population before I go into that, but remind me of that because I might forget.
Okay.
Which is that when we sit down with somebody to do treatment, the author of that treatment is really the client almost all the time. If they don't want to take medication, they don't take medication. If they want to tweak it, if they want to do something, if they don't want to talk about their voices, if they do, if they want to calm down, it's driven by them and not us, right? Because we need to respect what they want. They've not been in control of their lives for so long because other people have stepped in. It's really important to the best of our ability, as long as nobody's getting hurt, right, that they take as much responsibility as they can for driving their own treatment. So when it comes to actually working with somebody to de-stimulate, mindfulness activities work very well, but it does need to be tweaked for this population, because we know that when we try to calm down and be silent, the more we calm down, the more our prefrontal cortex begins to activate. which is why meditation is very hard. We try to sit and all of a sudden we're thinking about every grocery list, everything we have to do, right? And so if there is something to focus on, that's much easier to do. So we direct attention to a voice, usually, and that is our voice. Hearing something externally does tend to help.
Interesting. Mm-hmm.
So, for example, listening to music is a good way to sometimes drown out the voices. Putting really odd things like putting an earplug in the left ear that seems to help for some reason. I don't know why. But so we want to make sure that we don't do mindfulness with long periods of silence. Right? We don't want that. We want soft, guided meditation. We want to teach the individual how different outside stimuli creates a different experience inside. So if I'm listening to death metal, hard rock, I have one experience. When I'm listening to lullabies, I have a different experience. If I'm watching those vicious Halloween movies, or if I'm watching, I'm trying to think, Little House on the Prairie, right? I'm going to have a very different emotional experience. And so training people to attend to most of the stuff around them, to not do the horrible shows, to not do the loud stuff, to not do the exciting TV, particularly right before bed. But, if they're feeling vulnerable to symptoms coming on, stay away from that, right? And so we'll guide them with breathing, with meditation. Sometimes we'll do a chant, write it down, have them put it on their wall, reminders all over the house, something that they can do that nobody knows they're doing, so that they can do it in public without anybody having a guess as to what's happening. And I do that when I'm beginning to feel panic in front of a crowd. When I train, I'll do some of that on my own so that my audience doesn't know that I'm sweating underneath my clothes. Right? So it's a very normalizing thing to begin to calm down myself. Right? Does that help?
Yeah. So am I understanding it right? That mindfulness is, in this context, is changed so that the experience is not focused on going inside or inward and just being silent and just observing yourself, but a little bit more outward. So like kind of anchoring with the music, for example, or sounds, or this kind of things.
Or behavior, right?
Right.
For example, I practice mindfulness when I'm doing my dishes, right? Which is an outside activity, but it also helps me to do the dishes because I feel like I'm doing it for some higher purpose, I guess.
Perfect.
It gives me a better feeling about it. Yeah.
And the way you described it is that a lot of these treatments, it seems to be about not just building that, as you described it before, that relationship with the hallucinations or the voices, but also the relationship with the external world. So like you said, like learning how the external things, how impact you. Very interesting.
Yeah, absolutely. And reality testing, if a person is able to do that, right? Some folks with schizophrenia, I want to say probably around 30%, but take that with a grain of salt, have a symptom called anhedonia. Are you familiar? You're familiar with that term?
I don't think so.
Anhedonia is a thing where you don't recognize that anything is wrong, but something obviously is. For example, people without a limb will experience phantom pain. Right, that's an example of anhedonia. It's the brain's kind of inability to update itself from one moment to the next. And so as a result of that, it's hard for them to remember that anything is wrong, right? And when it's not a limb, it's much harder to recognize. That too looks like I'm not paying attention to you, or I don't hear you. right? And that also gets a lot of criticism when in fact it's not an effort to deny something, it's a sincere inability to update my brain to what's happening. So that can make things harder. With treatment, oftentimes the anosognosia can remit, particularly if the client is willing to take some medications and do some hard work in therapy. Sometimes no matter what happens, that anosognosia just stays right there. And if that occurs, then what we do is to help them develop a relationship with themselves and the outside world in a way that's most meaningful to them, even if the delusions and the hallucinations persist. Right? So we work on reducing the distress with the symptoms and building a sense of how much can I do? What are my strengths? Structuring my day, accomplishing something, making meaning out of every day, right? Is still
creating more autonomy.
Yes, absolutely. Yeah.
Okay. There was one more thing I was going to ask you, and I kept thinking, like, how do I fit it with other questions? So we briefly talked about it before we started the interview, that merit, which is a therapy for psychosis, and I was curious. I'm not sure how much you know about this therapy in specific, but I'm curious what your thoughts on implementing or helping patients to develop metacognition. Is that something that is part of the treatment, or?
Yeah, for CBT, it is part of the treatment. Third wave therapies have really made a big inward step with metacognition, like acceptance and commitment therapy really encourages metacognition. And the merit, I don't know a lot about. I just pulled up an article, probably 15 minutes before I hopped on the call here with you. But it is absolutely compassion-focused way for the individual to begin to be aware of their own thoughts and their own structure, right? And decide what they want to do with that. So I've only seen one small article on it, and it looks fascinating. I would, in fact, I'm thinking, wow, we ought to be doing this at the best center at the medical university where I work. That's pretty cool, right? So I do try to do metacognitive techniques with my clients, and on occasion, even with anosognosia on board, even with that lack of knowing that something's wrong, that can be really helpful to do. And it can be as simple as imagining oneself as being the center of the world, right? If we were to draw just a circle and I see myself center, so putting oneself on the outside with everybody else and looking at the situation. And that little switch sometimes will help. Or to ask somebody to kind of observe self from above, right? And if I'm having a terrible thought about myself, right? When I'm above watching myself have a terrible thought about myself, who's watching? Oh, there must be some part of me that's not terrible, because here I am being able to see that, right? So those kinds of little tiny tricks, once you know the client, is really fun to do, and it's fun to do with yourself as well.
Right. So it sounds like it's mostly focused on the metacognition in regards to yourself and your state. The reason I kind of got interested in that, because lots of people with schizoid personality, I would argue they actually have too much metacognition, like they so far out in terms of, like, maybe seeing patterns and like how the world works, and they got very interested in, all the bigger picture. But there's not much maybe metacognition about oneself, although there could be too, maybe. So I'm trying to understand that.
I'm guessing that schizoid is a real difficult mix of I want to join the world, but why bother? Because it's not going to work.
Yeah.
But I really want to, but people are going to criticize me. But I need to connect with somebody, but they're going to reject me. And that self-defeating belief system and the desire to be outside, that's gotta be hard. That's just gotta be a hard way to live. And so being able to recognize that that's what one is doing and how maybe that helped them at some point in their life, but now it's not working so well, might be the way to go.
Maybe.
Right? Middle ground, or to see that as a polarity. And, in Gestalt, we talk about polarities and coming and finding the middle somewhere.
Yeah. Interesting. Yeah, it was just curious because maybe on the first sight it seems like, why would you want to develop more metacognition? Like you're already like
Yeah.
too many things at once. But I guess when it comes to maybe self-awareness and how one is creating that experience for themselves, I think that could be helpful.
True. And the other piece of that is learning how to read others, right? So people with schizophrenia have a very hard time reading other people's face and body language and tone of voice, right? So a lot of that is social skills. We teach a lot of that, and we practice a lot of that as well, so that they can begin to experience themselves in a different way, but also begin to read their environment differently as possible. Recognize that, a lot of people will look down all the time and will look up, and when they look up, they see, oh, that person's not looking at me. They're fixing their hair in the mirror, or they're dropping their mascara in the coffee cup as they're driving. They're not looking at me. And so they begin to be aware, right, that they can lift their eyes up and see, and begin to practice reading what's happening around them, which is very helpful to touch base with reality a little bit more. Because when we have our heads down, we're fantasizing about what might be happening on the outside.
Yeah. But I would imagine, like, apart from, maybe the schizophrenia related symptoms, there is all this bunch of, like you described before, a whole bunch of things related to negative symptoms where they've been misunderstood or judged for, like, being lazy, for example. So I guess there's that bit to deal with as well, not just the schizophrenia symptoms, but also the self-worth and confidence and feeling like you can actually, make sense of what's happening and be this autonomous individual.
Absolutely. I love working with this population more than any other population. I love this work. It's a great population to work with.
Do you mind sharing why?
It's like pairing up with your client. You're both on equal footing. This is the way that I like to see myself, as not knowing more than them, or them knowing less than me. But if we put our efforts together, we're kind of like a detective team. And we can kind of figure out together where all of these things may be coming from and why they might happen. So I had a client whose voices would tell him that they were going to murder his parents if he used drugs again. He had been heavily involved with drugs. Well, that kept him sober, but it scared him half to death too. So when we talked about it, we reframed the voices as a way that those voices were trying to help him stay sober, albeit very inelegantly and kind of a mean way. But it was the piece of him that wanted to stay sober, maybe. And so when he began to think of it that way, it wasn't quite so nasty. Do you know what I mean? Right?
Right. So his relationship with the voices changed to more positive and more accepting.
Right. And the voices changed with him as well.
How did they change? Did they go down a little?
they stopped threatening as much. He also stopped using. He did go back to using for periodically. He would go back to using, but longer and longer he would stay sober. Finally got out of the court system. And the last I knew, he was doing just fine. So the voices, he was able to think about the voices as something that was his brain was doing, and it wasn't about him. It wasn't about that he's crazy. It was some weird thing his brain was doing. He was just going to kind of accept that and tolerate it and go on with his life.
Wow. Yeah, I find it all fascinating that maybe in some situations the medications are really not that necessary. Like,
Well, they do
I would
help.
imagine depends on, yeah, I would imagine, yeah, it depends and they are helpful, but it's not just the only way to deal
Oh
with
no,
schizophrenia.
right. Absolutely. Talk therapy can be very, very helpful if it's done well and done correctly. And I think we have a lot to learn about over medicating, because it's easier to do that than to have to manage sometimes. And that's something that we may need to look at, or to be very restrictive with them, because it's easier when we're in control, right?
Mm.
So we end up being very restrictive, and that's not very ethical or kind even in any way. So people who think people with schizophrenia shouldn't get married, shouldn't have children, shouldn't drive, shouldn't vote.
Yeah, that's horrible.
It's horrible. It's horrible. And so learning that these are individuals just like you and I, and a lot of times I think of their voices the way that I think of my negative thoughts. Right? If my negative thoughts were out loud, I'd be hearing what they're hearing.
Yeah.
And so that's the way I like to think of it. And so when I'm working with them, I'm kind of working with myself too.
Yeah. Yeah.
Or reinforcing what I've learned with myself. Yeah.
Yeah. Perfect. Well, thank you so much, I guess, for all your work, because I haven't heard many cases of people or like psychotherapists or clinical workers who respect that other people have their own experiences. Like even people with schizophrenia have their own experience, and it doesn't mean their experience is completely wrong or invalid. And you're approaching it from this place of that respect and kindness, which is very,
Absolutely.
very nice.
Yeah. Yeah. I love it. I love this work. It's great.
Perfect. Well, Valerie, I would love to keep asking you questions I could be doing it for hours and keep probing your brain basically. So it's a very, very interesting subject for me, but I think it's a good place to stop. And I really thank you for your time and the contribution that you've made. And I'm sure lots of people with schizoid personality will be very happy to hear about all the subject that we talked about
That's
today.
lovely. That's lovely. Thank you so much for asking me. It was fun.